Okay, seems like we've got, I think we've pretty much got the full complement here. So why don't I just share my screen? So, one second. All right. Good morning, everybody.
Good morning.
Thank you for joining.
Good morning.
All right. So everybody can see the screen now, is that right?
Yep.
Yes.
Perfect, thank you. All right. Excuse me, let's move on. All righty. This is an 11-year-old with a history of palpitations. And this is a ZO patch that was recorded at just a few weeks ago. And this is seen at 6:18 a.m. So I'm going to talk to Dr. Barris and ask him what he thinks about this tracing, what would he do about this, et cetera.
Good morning, Dr. Pass. So history of palpitations. Now we're looking at the ZO. I'm starting at the top line. And I see immediately that I see one P wave without a QRS complex behind it.
Mm-hmm.
Just trying to figure out if that's a blocked PAC or if there's some sort of heart block going on. And then I'm scanning the second line. I'm not seeing any additional blocked beats. The other thing that catches my eye is the second on the top line, the second, third, and fourth beats look like there's maybe a little more like a premature upslope of the QRS, almost like a delta wave. I'm not seeing it consistently.
Mm-hmm.
So in terms of these palpitations, I'm thinking, either PACs because I see that one blocked one versus like a Wolf Parkinson's white, because of that upslope on those few beats there.
So what is the PR interval, David, on most of the beats?
PRs.
This is a very nice, clean tracing.
So it's like I see like 200.
Okay, I agree with that.
So that would be long for 11-year-olds. So that'll be at least first degree.
Right, and the other question I have is you indicated the possibility of preexcitation. Is it likely that somebody would be pre-excited with a PR of 200 milliseconds or roughly 200 milliseconds?
I would say it should be close. It should be less. It should be far less.
Yes, exactly. So although I agree with you that the QRS is a little bit on the wider than average side, and there is some sort of an appearance at the start of it that looks pointing here a little bit like a delta wave. The reality is that with this sort of a PR interval, we certainly don't have pre-excitation, or at least not on any. The other thing is this beat here, I think you would agree that the PR interval is even longer than this beat. Do you agree with that statement?
I do.
Yeah, and yet the QRS morphology looks almost identical to this one, very, very similar at least. So I think that it would be, I guess what I'm trying to say is this is not pre-excitation. This is actually just an example. I agree with the computer. This is likely a form of Mopitz 1 block, right? We have a PR prolongation from this beat to this beat, and then there's a P wave that is not conducted. Now, if you actually time out these P waves, this P wave is premature. So I guess officially you could argue that this is a PAC that didn't conduct, but all I would say is, if you figure out what the heart rate is, let's say between this QRS and this P wave, it's a rate of roughly 100, right? And so we would expect an 11-year-old, even if this were a PAC, what this probably is just sinus arrhythmia with Mopitz 1 or a Wenckebach. But it is interesting that this P wave should still conduct. right? I mean, a normal, healthy young person or even a healthy older person should be able to conduct a P wave at this interval. So this is Mobitz 1. So I guess my question then is, so now you've made this diagnosis, you have seen this 2 or 3 times. I will remind you or just point you to the fact that it says this occurred at 6:18 a.m. The mother tells you that her son was actually wakes up routinely at 7:15 for school. So this is while still asleep. So is this, would you do anything about this? Would you not do anything about this? Do you think this has any relationship to this history of palpitations? How would you think about this?
I'm not sure if it has anything to do with the palpitations. Um, I mean, I feel like, first degree heart block is something that we would see more commonly, but second degree, I think, is something that we would probably act upon.
So the first thing I would say is yes, first degree heart block we do see, but it is abnormal, right? I mean, normally we should not have first degree heart block. Now, it doesn't mean that it's necessarily dangerous, but this question always comes up when you meet a patient who has first degree heart block. What do you do about that? And so we normally will do things like look for inflammatory markers consistent with myocarditis or endocarditis, which can sometimes cause a PR prolongation. We look at things like the thyroid levels, hypothyroidism in particular can cause PR prolongation. But the Mobitz one, the reason I'm just showing this is a very common, typical finding that we see on Holters and Zeos and any kind of ambulatory monitor. You'll see this in the hospital on telemetry not infrequently. This is a normal finding in a healthy person to have Mobitz 1 block. But in reference to, so I would not be particularly bothered by this finding, particularly if it was seen only when the patient was asleep. It's very common to see that when patients are asleep. But it is interesting to see this PR interval being long. And so when I see a patient with first degree heart block, I normally will, at the minimum, do a Zeo patch or a Holter or a Barty device, one of these longer term monitors, just to make sure that where there's smoke, there's not fire, meaning that there's not any higher level degrees of block. And in fact, in this patient with first degree block, there is Mobitz 1. Now, Mobitz 1 we've said is normal. This would not particularly get me nervous, but I would definitely say, someone with first degree block, the question then becomes what do you do with that patient? How do you follow that patient? Do you follow that patient? My personal bias is that if the PR interval is stable over a few years, I won't continue to follow the patient. But I have had a handful of patients with first degree block who have progressed over time when we did not know the etiology, and even one who ended up in the emergency department after following her for 8 or 9 years with first degree block, and she came into the ER after a syncopal episode in which she was in complete heart block. I never really understood what was wrong with her node, and she ended up, we put a pacemaker in her. Okay, let's move on to that.
Dr. Pass,
Yeah.
sorry, this is Neha. I had a question in that tracing. So in first degree heart block, isn't the PR prolongation greatest with the first beat? And, it does prolong progressively and then there's a drop beat, but usually I thought that the first beat is the longest jump in the PR and then it continues to progress and drop. But here it's a little odd that the last beat before the P is dropped is the
long.
Yeah.
Well, I'll be honest with you in saying I'm not familiar with that concept you've just espoused. I think that more likely what you typically see, of course, in Mobitz 1 is that the PR interval lengthens with progression until you drop a beat. I'm not familiar with the notion that the first PR in somebody with first degree who also has Mobitz 1 will be the longest PR. That said, this is certainly not a short PR here. I don't know if that's true, Neha. I'm sorry. You might be right. Okay, let's move on. This was a patient that one of my colleagues here at Mount Sinai asked me to look at this Holter from a different hospital. This is a 9-year-old with WPW, which was identified incidentally during a invasive dental procedure, which required general anesthesia. And this is the halter that was obtained. And so just for those of you who haven't seen many halters, typically when a halter is performed, the technician will print out strips that are abnormal or representative of the rhythm. We don't do that many halters anymore because we've been doing a lot more Zeos, but we actually do have a halter system here, and Robin Berry, our technologist, will go through it, scan it carefully, and show us what she thinks is important. So this is an example of a halter outside, and patient had WPW or has WPW. So this is what the doctor saw. So my question is, do we need to do anything about this? Why don't we ask our now hopefully board certified cardiologist, Jenna, if she has any thoughts on this, Tracy.
All right. So in the first line, it looks like there is probably tachycardia. I'm trying to figure out
Let me interrupt you, Jen. I apologize. I just want to say it's obviously impossible to know what these heart rates are because there's no lines on this page. Suffice it to say that this strip is at a rate of about 120. This is about 90, and you can go on and on from there.
Okay. So looking at the first strip, it appears as though there is a P before every QRS. It's a regular rhythm.
Mm-hmm.
I don't know which leads we're looking at, but the P wave looks upright in both of the leads that are there.
And that's a very important point you're raising, which is it's very difficult without a 12 lead to know for sure if you're in sinus rhythm. I think what it says we're in an atrial rhythm, but usually one of the leads is supposed to look something like lead 2, but that is not always true. So anyway, please proceed. I'm sorry to interrupt you.
And it looks like there is a short PR interval with a delta wave at this rate of 120. So I'm thinking this is probably a sinus tachycardia, but it could be a long RP tachycardia potentially, which would include in the differential an EAT, PJRT, sinus tachycardia.
So that's certainly possible. But again, you have to always, common things occur commonly, right? And so this patient has WPW. So it would be a little odd to also have PJRT or EAT, right?
Yeah. So I think this is most likely a sinus tachycardia.
So, first of all, why do you think this referring doctor did a Holter in the first place? What were they looking for? What was she looking for?
So could have been looking for just any runs of SVT.
Okay. Some patients are not aware that they're having tachycardia. Usually they are, especially a 9-year-old, but not definitively. So that's absolutely true. I'll tell you that this 24-hour recording did not demonstrate any tachycardia.
Okay. And then the other thing they could be looking for is whether the preexcitation is intermittent or persistent, depending on what the tracings in the office have looked like.
Right. Okay. That's exactly right. That is the other reason that this Holter was performed, was to see if there was evidence for so-called intermittent preexcitation. So do you see any evidence for either persistent preexcitation or intermittent preexcitation here?
I mean, I think looking at all of these, it seems as though there are periods where it's not pre-excited, like in the second line.
Right. And so so this is exactly the truth. That's very astute of you. So yes, so this second line does not show pre-excitation, right? I think we would agree that the QRS morphology is a little more narrow. You don't see a delta wave in the second tracing, and this is at a heart rate, it says, of 83. So we have an odd situation in that the heart rate here is 83, and we are not pre-excited. And here we have a heart rate of, let's say, 120, and we are pre-excited.
Mhm.
So the question that the doctor asked me was, is any more formal testing required? So I'll pose that question to you.
Yeah, I mean, I guess the way I might think about this is similar to like on a exercise stress test, where you would consider it higher risk if the pre-excitation persisted at higher heart rates.
Yeah.
In which case I probably would do an EP study in this patient.
Right. So it's interesting. You're right. That would be the formal recommendations. But again, the fastest rate we're looking at on this particular page is only about 120, right? And we know what would high risk be? How fast do you have to go through the accessory pathway in order to denote at least not low risk, let's say?
So the cycle length of 250, right?
Right, so cycle length of 250, which is roughly a rate of 250, that would be where we would start being concerned about the risk for sudden cardiac death. What's odd here, of course, is that at the faster rate, we're pre-excited, but at the slower rate, we are not. Usually it's the other way around. So
Right.
these strips are interesting in that the patient has intermittent pre-excitation, but they're not exactly conforming to the rules where we would expect that pathways at faster rates that are wimpy pathways that can't conduct fast would not conduct. So just to remind everybody, there is in fact a consensus statement that is very commonly referenced. It's hard to imagine already that this is from 8 years ago by Mitch Cohn and the Pediatric and Adult Congenital Electrophysiology Society, of which I am a member. This is the algorithm that they recommend, and this is the formal recommendation. So you get the baseline electrocardiogram. Again, this is for the asymptomatic WPW patient. Now, what it says here is that if you have intermittent pre-excitation, follow in cardiology with counseling regarding symptom awareness. If there is persistent manifest pre-excitation, an exercise stress test is recommended. And as Jenna said, if there's abrupt and clear loss of manifest pre-excitation, again, it needs to be abrupt and clear, then again, nothing further is recommended. So if you have a stress test and you have abrupt and clear loss of manifest pre-excitation, or if you see intermittent pre-excitation, the formal recommendation of this statement, which is still the standard one, is that we would follow in cardiology with counseling and just say, call us if you have a symptom. If, however, on the stress test, there is persistent or uncertain loss of manifest pre-excitation, which I'll mention is almost always the case or is very commonly the case, then it is recommended that a diagnostic or a transesophageal study be performed. And then, as Jenna said, we're looking at the shortest pre-excited RR interval in AFib at a rate less than, it says greater than, but it's really less than 250 milliseconds. I see. If it is greater than 250 milliseconds and there's an absence of inducible SVT, then most doctors, class 2A, would recommend follow in cardiology with counseling regarding symptom awareness. And some doctors would consider ablation depending on the pathway location or the patient characteristics. If the shortest pre-excited RR was less than 250 milliseconds, then basically most would recommend ablation, assuming it's safe. And then if there were inducible SVT, a lot of doctors would recommend ablation. And our general approach is that if the shortest pre-excited RR interval is less than 250, or if we can easily induce SVT, we will typically recommend ablating that pathway. Interestingly, this is the same patient with a maximal heart rate. They're showing us the maximal heart rate of 182 beats per minute. And at this rate, we are not pre-excited. And so based on these findings and based on the formal recommendations of the PACES organization, and that statement was endorsed by the American Heart Association, as well as the American College of Cardiology, it would be standard to not proceed with any formal EP testing in this patient. In in the setting of an asymptomatic WPW patient. Now, I will tell you that there are rare cases reported in the literature of people who shall we say, passed this test of a stress test or intermittent preexcitation who have gone on to have life-threatening arrhythmias or even died suddenly. It is extremely rare, but there are rare cases of this. But those cases are sometimes used as a rationale by some electrophysiologists to proceed with ablation. Just recently, I saw a patient for a second opinion from another center where the electrophysiologist actually cut and pasted abstracts of 3 case reports of patients who had intermittent preexcitation and then went on to have a life-threatening event as a rationale for going ahead with ablation of a pathway. I'm not saying there's a right or a wrong answer. This is highly controversial, but I think increasingly a lot of electrophysiologists are saying to themselves that if they think the pathway is in a safe location, it might be worth trying to ablate. I haven't personally moved that direction just yet, but I definitely see the rationale for it. Okay. Alrighty, this is a 1-month-old following tetralogy of Fallot repair. I think I noticed that we have with us Dr. Rajan Nivi. Are you on the line there? Did I see you before?
I am. I'm here.
How are you?
Good. How are you?
Well, thank you. So let me just orient you. One of our fellows, maybe it was even you, made this tracing. We're looking here at the standard leads 1, 2, 3, R, L, and F. And at the bottom is actually an atrial electrogram that was obtained. And I want to thank the fellows for providing me this very nice tracing. So what do you think is going on here?
So it looks like, let's see. So I'm not seeing any clear P waves. I am seeing a little bit more of a wider complex QRS.
Yes, I agree with that.
And it looks like a tachycardia. So I'm going to go with jet.
Okay, so that's always a good guess when we're talking about a G patient, and might in fact be correct. Anything you surmise? The only thing I would say that went against that diagnosis is the presence of a wide QRS. But
That's right.
Can you think of any reason why a patient could have JET and have a wide QRS? Because they are not mutually exclusive.
Let's see. If they already had damage to, I guess, one set of Purkinje fibers or something like that, they could have widening.
Yeah, you could have another way of saying that would be you could have a bundle branch block, which is not uncommon. This particular patient, I understand, needed, in order to close this VSD, a little more extensive. I think a small ventriculotomy was actually performed. So not shocking that the QRS is wide. Does the atrial electrogram help us in any way?
Dr. Cross, remind me which one the atrial electrogram is once again?
These are the bottom 2 leads. I think the more clear one is V3. I think this was expertly shown to me by Dr. Aluwalia. So, Neha, you're not allowed to speak in this particular case.
It still looks like there's an absence of QRS complex. It looks like there's some sort of bundle branch block. There's an RSL prime. I don't know if this is leaning more towards like a picture of SVT with aberrancy.
So the first thing I would say is when you're talking about SVT, I assume you're referencing either AVNRT or ORT or pediatry, but this rate is a little slow for that, right?
Gotcha.
A 1-month-old with SVT, you would typically expect the rate to be more like 300. Also, remember what an atrial electrogram is. It's a recording directly from the atrium itself. So although I agree with you that this looks like an RSR prime, this is really mostly an atrial depolarization. So we're using this in order to figure out where are the P waves. And if we, in our mind's eye, look up from where this sharp spike is to where the QRS is, I think you would agree that they're essentially on time with the QRS, right? They're on time with the QRS.
Gotcha.
So the question is, so this is some kind of a tachycardia, possibly JET, possibly VT. with with a one-to-one relationship, the P wave is occurring on the QRS. It's also possible this could be sinus tachycardia with a very long PR interval, and the P wave is actually buried in the QRS.
Okay.
So, so a maneuver was done. This is rapid atrial pacing, and I'm going to just show you here. So on the right-hand side is what we were just looking at, the spontaneous arrhythmia. And on the left-hand side is the rapid atrial paced rhythm. So the first question I would ask, so we had a differential diagnosis. The first question was, could this be sinus rhythm on the right with first-degree heart block? Here we're pacing at a slightly faster rate. Is there anything about this tracing that tells you that this was not sinus rhythm with first-degree heart block?
It looks like, I mean, the QRS is still wide.
Right, and they look exactly the same in both
Yeah.
tracings, right? It's exactly the same. That's why I've lined them up like this. So that would rule out the presence of VT, right? Because when we're in an atrial-based rhythm, we're going down the conduction system and the QRS looks exactly the same as in the spontaneous arrhythmia. So it would be unusual for VT to have the exact same QRS morphology as a sinus rate or an atrial-based rhythm. So we've ruled out VT by this very nicely demonstrated atrial-paced rhythm. Have we ruled out the presence of first-degree heart block in this tracing by rapid atrial pacing? And again, we're pacing slightly faster on the left-hand panel than we are in the right-hand panel.
I don't think so. I'm not sure why though.
Okay, so actually we are proving that there is not first-degree block. And the reason I say that is because when we're pacing at a faster rate, our PR interval is only 3 or 4 small boxes, right? So if this were first-degree heart block at a slower rate, it doesn't make sense that the PR would, we showed on the atrial electrogram that the P waves are occurring simultaneous with the QRS. So the only way that this could be, first-degree heart block would be if when we pace the atrium, the PR is even longer. So the fact that the PR is actually shorter when we're atrial pacing at a faster rate implies that this is not first-degree block, because if it were a sinus rhythm with first-degree block, the PR would be shorter than this, because at a faster rate, we actually have a shorter PR interval. So by atrial pacing, we've demonstrated that the QRS morphology remains the same, ruling out VT. And we've also demonstrated that the PR interval is even shorter at a faster paced rate, suggesting that this rhythm on the right is in fact junctional ectopic tachycardia. This patient was easily managed with pacing maneuvers and reduction of inotropes and such, and did well. So
can I ask a question? Why in the previous scenario, I'm sorry, in the scenario where we're just looking at this possible jab with wide QRS, like, why is it important to rule out a first-degree heart block?
It's not that, it's actually not that important, but you invoked that as a possible etiology.
Right, okay.
And I'm trying to explain that this electrogram does show that the P wave is in fact occurring on time with the QRS. And so the question is, what is the rhythm? And one of the, in the differential could be that this P wave is conducting to the next QRS with first-degree heart block. But this tracing rules that out, because when we pace at a faster rate, if that were first-degree heart block, the PR ought to be very, very long, and it's not. So this is an example of junctional ectopic tachycardia, a very nice example. Thank you for that.
Thanks, Dr. Cross.
Why don't we move on to this next tracing? I'm going to ask Dr. Perna Bonsall. I understand you're there, Perna. Good morning.
Good morning, Dr. Cross.
So ablation energy is turned on at this point here. What's going on this tracing? This is
Okay.
not a high-level question.
Let me just take a quick look. Here in the MAP catheter,
Mhm.
sorry, give me one moment.
Take your time.
Just the interval. So the interval after increasing the ablation, the PR interval is increasing. If I So as soon as it says ablation on, if I look at the surface electrogram, you see consecutively the PR interval being increased.
Right.
So it suggests that we are like in first degree heart block, or maybe, I don't know if it dropped after that or not. I'm not sure about that.
Okay, so you have the right instinct. We always worry when we're ablating and the PR interval lengthens that we could be doing something bad. This is the time when you're saying that if you were in the room, you would have screamed off for the ablation energy. But the other thing, so this is actually a fairly straightforward tracing. I'm just showing it because I want you to understand, and this is a nice example of where everything is in the surface electrocardiogram. Okay, now sometimes it's challenging to understand what you're looking at because the paper speed is so much faster when we're looking at everything at much faster sweep speed. You see it here, this is at 100 sweep speed. So we're not used to, unless you're an electrophysiologist, not used to seeing the QRS looking like this, of course. But I think you would agree that the PR, as you said, is very short, right? And then all of a sudden the PR lengthens. But what also happens is that the QRS morphology changes, right? This QRS,
Right.
like look at this versus this beat. So and then as you astutely pointed out, we're looking in the MAP, which is the distal ablation catheter. In our lab, we just happen to call it MAP. And we see that what this actually is an atrial and a ventricular electrogram that are sort of squished together because presumably the catheter is sitting at the location of the accessory pathway. And typically what we would do during an ablation is we would measure the onset of the ventricular electrogram and compare it to the onset of the QRS. And you'll have to take my word for it, but this to me looks like we're preceding the onset of the QRS by about 25 to 30 milliseconds, I'm guessing. And you notice that as soon as we're basically, if you imagine that ablation goes on at this point on the screen, we have one pre-excited beat, and then the very next beat is no longer pre-excited. And then the other interesting observation, excuse me, is that the A and the V have now separated on the distal ablation, right? So here we have the A and the V sort of squished together. And now we see that when there is no longer pre-excitation, there is in fact a very clean A and V on the distal ablation catheter. So you're right, the PR interval did lengthen, and you're right to be concerned anytime we see the PR interval lengthen during an ablation. But in this particular case, this is a good lengthening because we have successfully ablated the accessory pathway.
So, but the beat subsequent to this, it seemed like the PR interval further increased, but it could be similar. It just appears. That's why I felt that it could be developed.
That is an astute observation. It is possible. You're saying that this beat, the PR, looks like it might be ever so much longer than on this PR. Might be, Perna. And I don't remember, this is an old tracing now. I don't recall what happened, but I will tell you this. This pathway was definitely close to the patient's AV node. And so careful observation during this is important. And this is why when I'm doing these ablations and Josie is at the computer, I'm always saying to Josie, follow the PR interval, follow the AV interval, make sure that that there's no change in it, because we're very worried always about the possibility that we're getting heart block as a result of our ablation. Okay.
Mhm.
All right. Okay. This is a 5-year-old patient of mine who had a epicardial pacemaker placed. And I'm going to ask Dr. Uzoma Obiaka. So the patient comes into my office. On the left-hand side, you have the program setting, which is VVI with a lower rate limit of 45 beats per minute. And so the question I have for you is, does this electrocardiogram suggest that there is a problem with this newly implanted epicardial pacemaker? Is Uzo in the room?
Who's always here? I'm sorry, I just got off the elevator and I knew that the timing would just be right. I knew I was going to get called the minute I get in the elevator.
I just like the fact that you refer to yourself in the third person.
Okay, so sorry about that.
So again, I don't know if you heard in the elevator, this is an example of a 5-year-old who had an epicardial pacemaker placed. The program setting is VVR with a lower rate limit of 45. Is this, does this electrocardiogram suggest that there is a problem with the pacemaker or the lead?
Yes, it does suggest. So I'm looking at the bottom strip. And based on that bottom strip, I mean, the first beat looks like the V is being paced, but then there's a retrograde P, and it's just all over the place. It almost looks to me like this patient is in complete heart block. Looking at this.
Well, again, I didn't say this, but I think it goes without saying, this patient is in complete heart block.
Yeah.
That's why he got a pacemaker.
Yes, that's why he got a pacemaker. So essentially, I think there's a problem.
So if the lower rate is set at 45,
so
I agree with you. There is total atrioventricular dissociation.
Yeah.
There's no consistent relationship between the P waves and the QRSs, and the R to R interval is largely unchanged. It's pretty fixed, right? Or more or less. And I'll just point out, here's a QRS, here's a QRS, here's one. And it's interesting, right? The P wave is almost larger than the QRS, but that's okay.
But then, like you pointed out, though, the lower rate limit is 45, and this patient is like at a rate of about 50. The ventricular rate,
right,
is at a rate of 50.
So, is there any evidence on this tracing of device malfunction?
I would say no, not really, because there is none, because the ventricular rate is exceeding what the lower limit was set at, so it hasn't had the need to kick in yet.
That is exactly correct. So good job. So this is an example of a patient whose pacemaker is working fine. Now, we can't really tell anything about the pacemaker. We can say that it is not under sensing, right? If it were under sensing, if it could not tell what the rate is, we've set it to say, we've told the pacemaker, any rate below 45, we want the pacemaker to pace. But it will be inhibited by any rate of 45 and above. And as Uzo astutely pointed out, the ventricular rate is a little above 50 beats per minute. And so what we can say from this tracing is that the pacemaker appears to be sensing adequately, because if it were not, it would be pacing into this rhythm, which is according to the pacing of program, it should not. So we can say the patient's sensing seems to be good. We have no idea, though, about what the threshold was, meaning how much energy is required to pace the heart in this tracing. So this is an example where if you saw this tracing, but you did not know what the program of the pacemaker was, I think you would naturally assume, as Uzo initially did before she had a chance to look at the tracing coming out of the elevator, that you need to know you would assume that the device is not working properly. Now, in this particular case, I intentionally left the rate at 45 because the patient on his Holter had many episodes, heart rates varied between about 30 and 100, and a lot of the time is spent above 45. So what I'm going to do over time is keep a close monitor on how much the patient is being paced by the device. People with heart block generally get slower as they get older, and they end up using their pacemakers more. And so what will probably happen is that as we see this patient in the office over time, as this 5-year-old gets older and older, my suspicion is that when we assess this device, I think the patient was paced like 30% of the time. But if this starts to rise, the percentage of paced beats starts to rise, then the patient will have chronotropic incompetence and will not be at optimal. And so I will probably then raise the rate and just say, okay, I guess the patient needs to be paced all the time. Right now, I'm trying to be fancy and see if we could save a little battery life by not pacing too much, because as you know, pacing is the largest battery drain of pacemakers. But I probably am going to be forced to increase the rate relatively soon. You could even have made an argument to raise it even at this visit. Okay. The reason I didn't raise it at this visit, of course, is that first of all, he's fine. And second of all, you may remember that when we put a pacemaker wire in, the threshold will rise typically in the first 3 months after implantation. And because of that, because we know that that is a common occurrence as the lead scars in, we will typically leave the output on the pacemaker at a much higher level, usually 4 to 6 times the threshold, in order to be certain that as the threshold potentially rises, there will never be a loss of capture. At 3 months, we generally believe that most pacemaker wires are no longer going to get any worse. And so we consider a lead that's over 3 months old to be, as we say, chronic. At that point, based on the threshold, we would readjust the output much lower, usually with a 2-fold safety margin in voltage to make sure that the patient has 100% capture. And we can feel more confident that the lead at that point, however the lead is working, whatever that threshold is, in the absence of an injury to the lead, the threshold should generally remain roughly the same. So one of the advantages, or one of the reasons why I chose not to increase the pacing rate, was the patient is perfectly fine clinically, but importantly, I don't have to pace that much at this very high output that I've left it at. My personal bias is to leave everybody at 5 volts and 0.5 milliseconds, which is a high output for a permanent internal pacemaker. But what I would hope is that we will, in 3 months, be able to drop that down to around 2 volts. And that difference, going from 5 volts to 2 volts, could add 3 to 6 years of battery life onto the pacemaker. So I always remind patients that it's very, very important to never miss that 3-month visit, because at 3 months, we typically will lower the output substantially, and that will have a very powerful impact on the longevity of the device. And I have, on rare occasion, met patients who never went back for their follow-up, and at 2 or 3 years after pacemaker implantation, their device was depleted. So that's a bad problem. So I'm very aggressive in reminding parents that if they're going to miss any appointment, they should not miss that 3-month visit, because at that point, we're going to make an important change in the pacemaker program, which could have a very important implication in terms of longevity of the device. I think at this point, we're at the 45-minute point. We'll stop for today. Thanks so much. Does anybody have any questions about this tracing? Nope, we're good. Okay, good to see everybody. I hope everybody has a great day. I'll see you in a few minutes at Sign Out. Thank you.
Thank you, Dr. Van.